have you join us as we talk to our wonderful panelists who will introduce shortly. All right.
So I'll just get started, even though I can't really see everyone that's in here. I'll get started with some. You want me to start with the introduction, the purpose before we get into the panelist introduction?
Yeah. Are you already set up? Are you on Facebook Live?
No, I can't access Facebook.
Oh, won't do it?
Okay. From my phone.
Okay.
I'm recording though. I can't record. Somehow
All right,
I can't
awesome.
access the live. And I can't see everybody.
Okay. Are you on your laptop?
No, I'm on my phone. Remember, my laptop, it went out.
Oh.
The laptop didn't go out. The Zoom went out on my laptop.
That's probably why. Okay. All right. Well, no worries, you all. So yeah, Mecca, why don't you go ahead and start us off, purpose of the discussion topic, the Style Effect Project, and then we'll roll from there with introducing ourselves and everyone else.
Okay, so welcome everyone, still admitting people. Thank you for joining us this evening. And so the name of this panel is Black People Don't Hang Themselves. We will be today dismantling the myths associated with suicide in the Black community. This topic came up because during the protest, it was a lot of memes going around about Black people, or Black men in particular, that don't hang themselves. Also, when I was growing up, it was myths about Black people don't commit suicide, which is absolutely not true. Being in this field and being personally affected by suicide, I thought this was an important topic to address. Also, recently during the pandemic, there's been a lot of celebrities that either kill themselves or have admitted to having suicidal ideations. So this has been prevalent during the times that we're in, and I wanted to have everybody in to educate about the topic today. And part of the ability, being able to do this, is because I am an artist recipient for Richmond Memorial Health Foundation, and it's called the Style Effect Project. And style effect meaning that we're merging mental health and fashion. We're correlating the two. And today, the fashion part, all panelists are wearing teal and purple to represent the colors for suicide prevention. September is worldwide, so we're going to get into the topic. We want up some experts in the mental health field from all over, and we have some questions, and we will allow you all to ask questions in the chat. And unfortunately, I can't go through Facebook Live because something's going on with my technology randomly. After all that practice.
I know. Awesome. So Mecca, you want to go ahead and just formally introduce yourself, and then I'll get into.
Yes, I'm Mecca Williams. I'm a licensed professional counselor. I've been working in the mental health field since 2003. I currently work as a therapist at an addiction rehab facility. I also supervise people who are trying to become licensed. They're residents in the counseling field. So that's just a little bit about myself. We've been doing these types of panels since 2018, I believe. Sorry, letting someone else in. But doing these panels, mental health education panels for the community since 2018. I think that's pretty much the gist of me.
Okay, awesome. My name is Tangee Moore. Tangee Augustin. Isn't that funny? Look, I just recently changed that, so it's still getting used to it. But I am co-owner and lead therapist of Avail Outpatient Counseling. My business partner, Dr. Shonrell Blackwell, is actually on the call. Hey, Dr. B. But we are the owners of Avail Outpatient Counseling. We're outpatient psychotherapy private practice. We also offer an array of holistic healing services to include yoni steaming, guided meditation, different things of that nature. And so we often offer community events. We're constantly being part of community events to basically embrace our community, but more importantly, educate individuals on mental health, and more importantly, breaking down the mental health stigma. So we're just happy to have everyone on this tonight. We're excited to have this discussion. A few things I want to just tap into before we get into introductions is, as everyone's coming on the call, we want everyone to remain muted. This is a panel discussion. So if we were in person, we would be addressing questions directly to the panel, and you all will be the viewers. And so the same is going to be on this virtual call. We'll address questions to just the panelists, who we'll introduce shortly. And then at the end, we'll look in the chat for any questions, comments that you all have dropped, and we'll address those at that time. So as we move in, I guess, Mecca, you can begin with introducing Anthony, and we'll go from there.
All right. So one of our panelists is Mr. Anthony Penn, LPC. Hi, Anthony. Is Anthony there?
Yes. Mm-hmm.
Okay. Anthony's a licensed professional counselor in the state of Virginia with 20 years of experience in the mental health field, working with individuals diagnosed with severe mental illness and those struggling to manage psychological and or emotional difficulties. Anthony has treated individuals in private practice during outpatient therapy, acute inpatient, psychiatric facilities, outpatient therapy programs, such as partial hospitalization, various group homes, forensic facilities, and he's currently managed a multidisciplinary program of assertive community treatment, which they call the PAC team, in Petersburg, Virginia. So that's Anthony Penn. Welcome, and thanks for being here.
Yes, yes, yes. Our next panelist is Asha Tarry. Am I saying it right, Asha? I want to make sure.
Okay, am I back?
You're still muted.
I was trying to unmute. Yeah, it's Asha Tarry.
Okay, so we have Asha Tarry, LMSW. She is an author, certified life coach, and award-winning mental health advocate. She is also the founder of Behavioral Health Consulting Services, LMSW PLLC, which provides consulting, counseling, and coaching to creatives and small business owners in the wellness and entertainment industries and educational sector. Asha has consulted with initiatives on maternal health, global workplace retention, and been a writer and speaker for several outlets focused on mental health. Thank you for taking the time out to come and be one of our panelists tonight. We really appreciate it.
Thank you for having me.
All right. Our next panelist is Natalie Clavon-Carter, LPC. Natalie is a licensed professional counselor with 8+ years of clinical experience, including residential substance abuse, community-based clinical services, outpatient therapy and private practice, crisis stabilization, and crisis intervention. She currently is a clinical supervisor for the Greater Richmond SCANS Family Support Program. Natalie is also the executive senior leader for the Greater Richmond SCANS PCIT, Parent-Child Interaction Therapy cohort, and co-chair of the Inclusion and Equity Committee.
Welcome, Natalie.
Thank you.
All right, and last but not least is Dr. Lakesha Roney, EDD LPC. Lakesha Roney has been a licensed professional counselor in the Commonwealth of Virginia since 2005 and registered supervisor for LPC, LMFT, LSAPT, and CSAC. Dr. Roney is the owner of a private practice, Inner Self Counseling and Consultation, and she's been owner of that practice since 2007. Inner Self offers a wide variety of outpatient counseling services, consulting, trainings, and clinical supervision. She's also the executive clinical director at Hype Counseling Services, where she helps with growth of clinical and program development. Welcome, Dr. Roney. And I just also want to add that tonight we did have another panelist, Tiffany Davis, who's a crisis stabilization counselor. Unfortunately, she was not able to be here tonight with us as she's experienced the loss of a family member. So she's in our prayers as we move forward with this panel discussion.
All right, so let's get into some of these questions, and any of the panelists can answer. If you have something to add after the one question is answered, please feel free. So the first question is, why are there myths in reference to suicide not being a thing in Black families and communities? Example, Black people don't kill themselves. That's what white people do. Why is it a myth?
There are a lot of reasons why that's a myth. I think one of the reasons is culturally, because of Black people as a whole having such a spiritual grounding, and having strong religious ties. I think that there's a stigma that Black people won't kill themselves because it's considered a sin. So that, I think that's part of it, and we've been socialized to believe that. And then because of Black and brown people not necessarily displaying symptoms of depression, the traditional DSM-5 symptomatic way, as being isolative.
We're talking about
spells.
Black people and suicide.
Pardon me?
Excuse me. If you're not a panelist, we're going to ask everyone to please place your mic on mute. And just for those maybe that just came in, the questions are being posed directly to the panelists, and you all are here as viewers. And if you have questions, please leave them in the chat, and they'll be addressed at the close of this event. Thank you. I'm sorry, Dr. Roney, can you continue?
And sometimes, especially Black and brown children, they may not present as a traditional depressed child, being isolative. They may not present with the traditional symptomatic depression symptoms. They may present as being angry. They may have outbursts. They may be more impulsive. And that may be their cry for help. And that may not be picked up on by their teachers or providers, that they're in trouble, or they may be depressed. It may be viewed as being oppositional. So I think that's the difference. So some people may have the idea that he wasn't depressed. He wouldn't kill himself because he was just angry, or he was just upset and rowdy. So why would he kill himself? Because it doesn't look like traditional depression.
Okay, so what I'm hearing is the way some of the symptoms may show up for Black and brown people, and also spirituality can play a role in that.
Most definitely.
Okay. Anyone else want to answer that question? Any other things to add?
Yeah, if I could just add to that, I would say another component that I've seen show up so much in our community is the shame associated with the way that we die. And so when I see or speak to people who are co-survivors of loved ones who have died by suicide, a lot of times it's the story around which we tell how someone passes away that we thereby attach to the memories associated with that. And so with suicide in the Black community, there is so much shame in general around mental illness, which is why we're all here tonight talking about this. And when you add on the component of dying by suicide, there's further shame into people in those deceased person's lives maybe going unnoticed, and those signs that the doctor spoke about being amiss, so that those who survived it feel also ashamed that they didn't see those signs early enough, and that those predictors weren't so visible, or that the way that we interpret mental illness sometimes also goes askew when we don't know what to look for. So when we learn of someone dying by suicide in our families or in our circles of friends, we oftentimes, I think, feel a lot of shame around that we didn't notice. And so then we carry these burdens of not talking about it more because of that feeling that comes up in us when we have lived alongside someone and not have seen those signs early.
Okay, so what I'm hearing is basically also shame. Shame plays a role in this.
Mm-hmm. In terms
and some
of
reasons
myth.
why that's a myth.
Mm-hmm.
Yep, the myth. The way it's done, and it's that factor.
Mm-hmm.
Anyone else?
Yes, I'll also add, in addition to the shame and other things that have been factored in, I think pride comes into play at times. Black people have overcome a lot, and I think suicide is seen as a sign of weakness. So oftentimes, we don't want to admit that even though life is hard, that sometimes it's harder for others and that these kind of thoughts and feelings can come in. So they will kind of, you know, some people will say, oh, that's a white thing or that's a weakness thing. We're stronger than that. We don't do that. And there's pride and denial as well.
Okay. Is that the Black people are so strong myth? Is that related to that too?
I definitely believe so.
Okay.
Yeah.
All right. Let's move on to the next question.
So what are some of the barriers that prevent discussions about suicide and mental illness in the Black families and communities? What is your take on that?
I think, you know, there's just a large discomfort with it. And some of that tying back into what I've kind of just referenced about the strength, or if there's a spiritual backing, you know, you pray and you give it to God, and there's no need for a therapist, there's no need for any kind of intervention. And so in some households, it may not even be comfortable for a child to be truly transparent with what they feel, or even adults going to their extended family members. They still may not be comfortable talking to aunts, uncles, parents, grandparents, you name it, because there has just been a tone that's set that we deal with things and we get through it, and we don't need to have extended conversations on it. At the end of the day, a lot of people have that mentality that either you can do something about something or you just kind of get over it and you just keep going.
Okay.
Yeah, absolutely. And so I hear that often coming up. It sounds like in terms of barriers, religion potentially being one of them. I don't know, what's some more thoughts that you all have on that? Again, the barriers that prevent these discussions about suicide and mental illness in the Black community.
I would add to that self-concept, because some of the families that I've worked with, the idea that if you're successful, such as you're educated or your children are involved in things or they have material wealth, that there's no reason to suffer. And so we have this preconceived notion, I think, that if our children are taken care of in certain ways, or if we're providing for them in certain ways, there's no reason to feel anything else but gratitude or thankfulness for what we have. And sometimes because our communities are oftentimes behind the other communities that we see, where the education and the language around feelings and emotionality are introduced much later than it is in white communities, we don't often have the language to point to what it's like to feel deeper sadness or loss or grief, or to have struggles with our education, our environment, racism. We have all of these different things that are coming at us at one time, yet sometimes not the presence of language to determine when it's becoming overwhelmed into something deeper, like a mental health stressor or mental illness. So lack of education, lack of knowledge around what to look for, and that piece of self-conceptualized identity with what we think we should complain about.
Excellent point.
Absolutely.
I think a big barrier for people is still the stigma of receiving counseling. I still have a lot of conversations with clients, their loved ones, even people in my own family, about receiving counseling and what that means. Because there's a lot of misnomers about just going to counseling. Like, something has to be wrong with you to go and get counseling. The mind-body disconnect. It's an understanding that you should go to your primary care physician for a physical, to get a checkup. And we believe in preventative care when it comes to medical. But when it comes to going to counseling, oh, something has to be wrong with you. Like, something seriously has to be wrong with you. It's not taken into account that counseling is part of wellness. And it should be looked upon as part of your wellness plan, because all of us have room for growth. For the most part, all of us have been damaged in some sort of way. And we constantly need to work on those types of things.
Yes, you're absolutely right, Dr. Roney. And at this point, I think that's a big barrier. Just our self-concept, like you all said, religion, like you all said, and just being able to acknowledge that this is an issue that I need to address and be willing to access services. Mecca, you want to move forward with the next question?
Yes. Okay. Explain the differences between suicidal thoughts with a plan, suicide attempts, and completed suicide. Anybody want to take some or parts of that? Suicidal thoughts with a plan, suicide attempts, and completed suicide.
I'll give that one a go.
Okay.
So a suicidal thought is essentially someone thinking about ending their life. For instance, someone may say something to the effect that, well, I think my family will be better off without me, for instance. Or they say something, more specific than that. I think I will go end my life, right? And then a thought with a plan would be, well, you know what? If I wait for my wife to go to work and I can go sit in my car in the garage and I can, end my life that way. Or, or if I own a handgun, I can use that to kill myself. Not only do I want to die, but I know exactly how I'm going to do it.
It's nice TV on.
Told you put on the way. So,
Thank you.
Yeah, so that'd be an example of a suicide ideation with a plan.
Okay.
And then I'm sorry, what was the other question?
The other two are suicide attempts and a completed suicide.
Okay, so an attempt, for instance, would be if someone ODs on medications, whether they be over the counter or prescription, or even those in a combination of alcohol, as an attempt to end their lives. And let's say they're found by a family member or a loved one or someone, and their emergency team is able to respond in a timely manner to resuscitate them if it gets there, and to just kind of help them recover. So that would be an example of a suicide attempt, or for instance, if someone cut themselves and wanted to bleed out and weren't successful, someone found them in time enough, or maybe they even changed their mind, right? Maybe they weren't really sure that they wanted to do this, but they started the process and they realized, well, wait a minute, I don't want to leave my family this way. And then of course the completion would be someone who was successful, if you will, in terminating their life, whether it be by overdose or something, by hanging, or by using a weapon, or so, a gun, for instance.
Okay. That was thorough explanation. Thank you, Anthony.
I'm just
going to summarize really quickly, so make sure everyone understands the differences between these two. Suicidal ideations is thoughts. Even thoughts like, I don't want to be here anymore. My family's better off without me. We would call that a passive suicidal thought. Then suicidal thoughts with the plan is, I don't want to be here, and I am thinking of ways to take my life. Maybe I should go hang myself. Maybe I should access my friend's gun. Those types of things. Maybe I should take 10 of these pills instead of the prescribed 3. The other thing is suicide attempts is actually attempting. And as Anthony said, maybe a person is found and able to get some help. And completed suicide is when the attempt is successful and they terminated their life.
Yeah, definitely. Any last thoughts on that one before we move to the next one?
I would just add a couple of additional steps when you're assessing for suicide risk. As Anthony stated, there is the ideation, there's the plan. After plan, usually look at intent, meaning are they really intending to do this? And then also if they have access to the means. So I'll ask them, if you're thinking about killing yourself, how would you do that? Oh, I would shoot myself. So my next question is, do you have access to guns? And if they do have access to guns, then that takes it up another step where you want to intervene before they can actually attempt and possibly complete that suicide as well.
Thank you.
Absolutely. Good. Really quick, there's a few people that for whatever reason we can't mute your mics for you. Can everyone just double check? There's about 3 people that don't have their mics muted. Can you please do so now? Thank you, guys. We just won't want to hear background noise and interfere with the panel discussion. And so moving on to the next question, and just so you guys know, I'm dropping the questions as we go through each of them in the chat. So if you're like, what question is this? It's actually in the chat as well. So the next question we want to pose to you all is there a difference between self-harming behaviors, such as cutting, burning, and a suicide attempt? Because people seem to get that confused. Oftentimes people feel that people that are self-harming want to kill themselves, and this is a sign of suicide. But I'll let you guys go further on that one.
Yeah, this is something that a lot of even people that are licensed struggle with. Self-harm is engaging in behaviors that may result in physical injury to cause harm, but without the intention of killing oneself. So those type of behaviors could be cutting, could be burning, even tattooing. But the whole purpose of the self-harm could be to release emotional pain. It could be to receive a dopamine rush, or to feel some type of feeling because of numbness, because there are a lot of people that are just numb and they want to feel some type of feeling. So they will cut on themselves or engage in some type of self-injurious behavior. And it has nothing to do with them trying to kill themselves. They are either trying to release that emotional pain, or they're trying to receive some type of feeling or some type of release, or again, that dopamine rush. If someone is really depressed, by cutting the skin, it's going to cause the brain to produce more dopamine.
And who wants to answer the second part about the suicide attempt? Dr. Roney explained the self-harming behavior, suicide attempts.
I guess I can finish that off. The suicide attempt is just the individual's attempt of taking their own life. Sometimes it can be accidental. A lot of completions of suicide occur accidentally. Sometimes people are going through a stressful event or a difficult time, and they have a thought that they want to go to sleep and not wake up. And they accidentally take more pills than they know their system is able to handle. And they I don't like to use the word commit, but they take their lives accidentally.
Or attempt to take their life, because sometimes they survive the attempt too. Right?
Sometimes they survive the attempt. And sometimes the attempt can be very tragic, and they may have to live with the consequence of the attempt, like a gunshot wound or paralyzation or different things like that after the actual attempt.
So it sounds like the fundamental differences are the intention. As you stated, that self-harming behavior, the intention is not to commit suicide or to attempt to commit suicide, but a lot of self-harming behavior, the intention may be to release feeling. But then when you're attempting to commit a suicide, that's the intention, is to attempt the suicide.
The attempt to take one's life.
Exactly. Yeah. And and to just add to that, like Mecca was going, the self harm or non-suicidal self-injury, sometimes as we refer to it, is just that. I'm trying to self-soothe. I'm trying to release pain. I'm trying to release anger. There's reasons for that. So like we said, the intention is completely different. It's not to complete suicide and take my life.
Exactly. And there are many different interventions that counselors and therapists can use with clients to help them change the coping skill. It's the maladaptive coping skill that they've learned in order to release the pain or release their anger.
Yeah.
Okay, so as a follow-up question to this question, and Dr. Roney, if you can answer this question while we're on that same topic, is what are some examples of ways Black people engage in self-harming behavior, in particular Black people, because different ways.
So I think beyond burning and cutting, maybe we can tap onto that.
Substance use, alcohol, drug use, risky sexual behavior. And one topic I think that we don't discuss a lot is gun violence and also suicide by cop. There are a lot of people that engage in very impulsive behavior because they may not be willing to take their own lives, but they may engage in impulsive behavior that put them in situations in which they may be shot by a police officer. Therefore, they're not responsible for their own death. So they may be dealing with anger, they may be dealing with frustration, they may have many symptoms of depression, maybe PTSD, but instead of taking their own life, they're going to engage in the aggressive behavior, be very impulsive, and commit a crime or just put themselves in a dangerous situation where a police officer would have to intervene and they could possibly be killed.
What about in some of the environments, maybe being killed by people in the environment as well?
Most definitely.
Yeah.
Okay.
Right, absolutely.
If I could add to that, I would say some of, depending on the age of the client too, it could be a different set of things that you see and a different set of factors. And so when I've worked with adolescents, I've seen gang involvement, initiations. You know, there are, I think, sometimes the less immediate means by which someone may harm themselves or want to die by suicide. So even when we look at the way in which our youth engage in risky behaviors, even when it comes to initiation, I've had clients who've also, sadly enough, been involved in things that they knew were potentially toxic for them on social media, engaging in certain behaviors online, including being at risk for certain things that we know about oftentimes, like human trafficking, which goes under diagnosed and remedied in our communities. So when we look at the different ages of people that we're talking about, whether we're looking at, you know, early childhood or adolescence or adulthood, it may look different in different age groups in terms of self-injurious behavior and also death by suicide.
Excellent point.
Yes. Yes. Okay. Natalie, this is based on our history working with crisis stabilization. Our next question is, what are some of the factors that place a person at higher risk from suicidal thoughts or for attempts?
So I can think of several factors, thinking through that. First, you know, a lack of coping skills, because the fact is things do happen in life, and if we aren't already equipped with healthy coping skills and mechanisms for that, that puts us at higher risk for suicide. Lack of social supports as well. I've seen it a lot with people who are facing addiction and they've burned all their bridges, so they have no connections to family, friends, they're ultimately alone. Trauma is a big risk factor as well for suicidal ideation, is because that can lead to mental illness and things if not treated that can make them more susceptible to that. So those are a few that I have just off the top of my head.
Thank you. Anthony, do you have anything to add to that?
As far as, you know, indicators for suicide?
Yep. What's some things that place this person at a higher risk for suicidal thoughts or attempts or attempts?
Well, I mean, you could say, you know, lack of access to healthcare would be one, right? You know, African Americans, you know, tend to be more at risk, and some for some diseases, you know, we represent in greater numbers, you know, and like hypertension, diabetes, things like that. So, in regards to not having adequate access to healthcare, you know, we sometimes don't, you know, decide that we don't need to necessarily take as great a care of ourselves physically. And so that kind of leads to the untimely demise and almost planned, you know, attempt to end our lives.
That's an excellent point. Lack of access
Absolutely.
to healthcare.
Mm-hmm.
All right.
And part of the lack
Yeah.
of access of healthcare is also there's such a low percentage of mental health providers that are people of color. And I think that's a huge barrier for Black clients, because they want to work with providers that look like them and can relate to them. And most of your counselor education programs are staffed by predominantly white instructors, faculty members, tenured faculty members, and then the percentage of students in those programs are oftentimes reflective of the faculty members. So we're putting out less providers in the field that look like the populations that we're serving. So we definitely need more providers that look like the people that we're serving.
Yeah.
And
Absolutely.
also the modeling of how families treat illness. If your family is one in which maybe they're accustomed to taking you to the doctor up to a certain age, and then at a certain point, maybe they don't enter the room with you because they want to give you the privacy, or you end up going possibly on your own should you need other preventative care, you know, the modeling of how you address getting healthy and staying healthy and preventing illness is also part of it. We also see that in not only private practice, but in group practices and medical practices, doctors over assume things about patients and sometimes do not ask very intense questions that are necessary to screen for mental illness early enough so that they can provide adequate interventions not only for the individual but the individual's family. So if you have a family member that comes in that possibly could be illiterate and can't read, you know, a prescription or know what the side effects are, you may not be able to get that prescription filled. Or if you don't know what the signs of a depressed child actually look like, especially for Black children, then you may not ask certain questions. If you don't have a relationship with that child or young adult's parents, you may not have that discussion beyond the waiting room or in the office with that person's family member to see what other resources that they need in order to access mental health services and medical health care. So there are just so many factors environmentally, within the family, within the school systems that don't appropriately or adequately address mental health and mental illness. And oftentimes we interchange those words as if they're synonymous when they're not.
Well, do you
Absolutely.
think that also has to do with a cultural piece? Because if the provider is, you know, really culturally aware of the population that they're working with, then they would consider the family dynamic. They would invite the family in. They would consider those aspects. But that is also the part of the barrier, because if you don't have the providers, or at least providers that are culturally competent, you're working off a Eurocentric perspective.
I think it's both. I think it's cultural on both parts. I think it's cultural on the part of the provider and on the part of the family members. We come from communities, again, where we don't sometimes investigate the things that our doctors tell us. And so we have family members who believe at face value, okay, you're well, you're fine. Either take this script or don't, do what you want and go home. And that sometimes isn't just from European American doctors, that's from a European centric mindset. Black doctor with that.
That's what I mean,
So,
yeah.
yeah, so I think that it's sometimes the perception that either we trust our doctors too much and we don't investigate the things that they tell us, and sometimes it's our leaning on them to know what's best for us, when I often find that clients innately know something is wrong, but they may not have the language or education or information to say what it exactly is. And if there's a barrier of mistrust, then that adds another layer of dysfunction into getting the help that they need adequately.
So Asha, like as we
Great
talk
points.
about as we talk about risk factors, can you go in talk about some diagnoses that are also risk factors?
Yeah, I mean, I work with a spectrum of people from different ages, and I have over my career, but more so now with young adults and adults. And some of the risk factors include people who have an incarcerated loved one, I have lots of people who have one parent or caregiver that's incarcerated. I have people who have, as early as childhood, multiple medical conditions in conjunction with a mental health condition, so we call that comorbidity. We also have people who are entrenched in poverty. We have people who are not getting adequate education in their school system. There are so many factors that prevent people from being able to know where to start in terms of what prevention would look like and on what level and how many steps it takes. So community violence, sometimes domestic violence in the home, a parent being sick, which now with COVID, we have a lot of people who are dealing with that in the household, to parents who are also caretakers for their aging or sick loved ones, which may lead to neglect. Or just overlooking things that if they weren't stressed, they would see, to parents and families having less resources, even when it comes to employment. The way that our employers are set up to not allow, or jobs that most times Black people work at, that don't allow for adequate time off to care for your loved one or to take care of yourself. There was a time when I worked for other organizations and you had mental health days. That's almost non-existent, if that even exists at all anymore. So those various factors in the environment, to the employers that we work for, to the community, to the relationships that we're involved in, all create high levels of risk factors that compound mental illness early. And it gets passed down through the genes generation to generation, should that not be intercepted.
Thank you. That's definitely a good feedback. So in summary, based on what all of you have shared, examples of factors that may put African Americans, the Black community, at risk for suicide is psychological distress, substance abuse, access to lethal means, social isolation, homelessness or socioeconomic status, family dysfunction, exposure to violence, maladaptive coping skills, and I would say a history of suicide attempts. Yeah.
Also, a relative who has taken their lives by suicide.
Right. Absolutely. Yeah.
Are there any diagnoses, like any mental health diagnoses that would place you at a higher risk?
Bipolar for sure. Especially you have to be careful if bipolar is misdiagnosed as depression. So if you only treat the depression and don't realize bipolar is present, the antidepressants could actually send someone into a mania, and they could actually attempt or complete suicide in that state as well.
Thank you.
Yeah. And I think it's important to note, sometimes it's hard with personality disorders, such as borderline personality disorders, because for those individuals, it's a pattern, suicidal gestures, self-mutilating behavior. And sometimes that can really be tough, especially for providers, to distinguish, like we talked about earlier, are you trying to attempt a suicide, or is this just non-suicidal self-injury? So many layers. But as we move into the next question, many say that for the Black community, Black men more than women commit suicide, but that women are shown to have more suicide attempts. Based on you all's treatment experience or statistical knowledge in suicide, which do you believe is more prevalent, and maybe what are some reasons for that?
Overwhelmingly, men, not just Black men, but men in general, take their lives by suicide more often than women. But statistically, males account for 81.5% of suicides in elderly men. And women overall have the lowest rates of suicide amongst all groups. And I'm not sure if that's accounted for by our social networks, our ability to commune and find supports, but overall Black women are not at the top, but Black men and Black boys. I read some research, 2018, for the first time in history, the rate of suicide for Black children between the age of 5 and 12 has exceeded that of white children. And more than a third of elementary school age suicides involve Black children. That's alarming. That are Black children within that age group. That's before they become teenagers. they're taking their lives by suicide. And they're Black boys. And that's my absolute favorite group to work with in counseling. I've always loved working with boys. And for some people, they don't like to work with boys, but I've always enjoyed working with boys because first of all, they might get mad at you 1 minute and then 5 minutes later, they're ready to play. But once they develop a trusting relationship with you, they'll tell you all their business.
Mm-hmm.
So that I really enjoy working with boys, but it's alarming that so many of them are struggling. So many of them, they can't find their voice. They're not able to seek help. And I do think that toxic masculinity has a lot to do with men taking their lives.
Mm-hmm.
Yep.
And that's another topic for a different day.
Right.
I think there's also a few other elements to discuss here, which include demographics. So, I was reading, similar to Dr. Roney, a couple of different evidence-based articles that point to this. And so I think WebMD said, that definitely boys and men continue to die more often by suicide, but then another CDC reports that there's been a rapid increase in girls actually dying by suicide. And I think it also depends on where in the United States we're talking about. Surprisingly, you may think that, in more urban areas, you'd see that because it's more congested, but actually in more rural areas, you see that people die more often by suicide. There was also a time when people tended to die by suicide more often in the fall and winter. Now we're seeing an uptick in the spring and summer. So there was another study I read in Chicago where we often hear these stories about Black kids killing other Black kids in communities where there's high poverty and unemployment, but we don't talk about how many of those Black kids might be actually dying by passive suicide or otherwise. So when we look at, I think, overall, the theme of just where are we speaking in terms of the ages and the demos in which we are looking at, it may be different in certain clusters of communities where resources are fewer, where kids may be dropping in and out of school, or adults may have fewer resources and working longer hours, so younger children may be home for longer periods of time under supervised. So it really depends on where those numbers are coming from, and sometimes it gets skewed based on who's reporting it. So as we know, even in recent months, we've seen a lot of people who are dying by hanging, and we don't often know if that's suicide or if that's homicide. So they're just so many different things depending on where reports come from and how things are being documented, if those numbers could be lower than we actually know them to be.
I want to add to that. It made me think about when we talked about the increase in young girls in suicide. I thought about cyberbullying as that being part of a risk factor, something that we need to consider. With social media can play into the increases in the age demo that we're seeing. And that's something to watch out for. Social media, and I would also say just dealing with gender issues, sexuality, that type of thing could be possibly a risk factor.
Yep, very true, considering the changing times. Anthony, I'm interested on your take on this and hearing, as a Black man yourself, what are your thoughts about those numbers?
Yeah, well, I agree with the previous comments. Especially the part about the women, young women now, being represented as a higher risk group. And I think it's the ages. I think Dr. Roney pointed to this, but I want to say somewhere between the ages of 5 and 12, and then even maybe 12 to 18. And suicide is like I think perhaps like the third leading cause of death in these age groups, and that's kind of alarming. And I until I looked at this stuff, I was like, well, wait a minute, this should be a public crisis. We should be talking about this a lot more. And my concern is that why aren't we talking about it more? So thank you, Mecca, and for doing this. But my biggest concern is like, why aren't we talking about it more? So hopefully stuff like this will allow us to have more dialogue, and hopefully people will be more apt to seek out counseling and supports.
Okay. Next question. Anthony, since you were answer that last question, if you don't mind taking this one. What are some common signs that indicate a person may be planning to commit suicide?
Yeah, sure. Well, you know, some of what classic signs would be, you know, folks giving things away. You know, even talking about, you know, sometimes you hear people make comments about, well, yeah, you know, life isn't, you know, what I want it to be. Life isn't, you know, things aren't going the way that, you know, I would like for it to go. You know, a little more melancholy or sad. A shift in how people normally present, for instance. Especially when folks, for instance, have experienced a recent loss where it's, you know, a loss of a family member, maybe even a loss of a job. Times like now, you know, with COVID, you know, there's a great deal of isolation going on. So, you know, just kind of, you know, understanding where people's frame of reference is in their communication, and being careful about, you know, what they are saying. You know, does somebody call you quite frequently and they stop calling you? Or in some instances, does somebody never call you and calling you more? So just kind of noticing some differences in how relationships are occurring, and reaching out to people. You know, whether people are reaching out to you or not. Those are some things that I think it's important to look at.
Thank you. Anybody else have anything to add to that question? What are some common signs that a person may be planning?
One thing that I found really interesting, and Anthony kind of reminded me of it because Anthony is a veteran. I attended a veterans and suicide training a few years back, and one of the key statements that you will hear veterans making is speaking of not wanting to be a burden to others. So ever since I attended that training, that's something that I listen to when I am working with individuals that speak of wanting to take their lives. If they mention, you know, I don't want to be a burden to my family, I feel like I've been a burden, I really start exploring the suicidal thought.
Okay.
That's a great point.
If I could add
one
thing, two things I think sometimes get overlooked are weight, especially with Black people, because if you come from a family that's very opinionated about your weight, and they point out, let's say, should you be one size and you dramatically lose weight, and they see that as a positive, but they don't notice that maybe there are other things that are contributing to your weight loss in order for you to disappear. That could be a sign. Even on the opposite end of the spectrum, when we overeat and overindulge in things and substances to numb our pain. And that for some kids who are younger, then increases the likelihood of childhood diabetes, heart conditions, asthma, etc. So I think that's one thing that we sometimes overlook. And another thing are the people in close relationships with people who die by suicide. There's so many co-survivors that, should they have been close friends or partners or lovers, that are sometimes not willing to live anymore when someone really close to them passes away. And the support that co-survivors really need, I think, is bountiful, and it's under researched as a topic, and it's often sometimes those groups of people who go into the margins that we don't look for.
Perfect. I also would like to add to that, what about anyone who has experienced a recent trauma?
Yeah.
Absolutely. Yeah.
A sexual trauma,
Yes.
By any other form of violence. Do you think that something to look for, to pay attention to as well?
Yeah,
Most definitely.
Okay.
Yes.
And another thing that I look for too is hopelessness. You know, a lot of people will commit suicide when they feel like their back is against the wall, there is no solution, this thing is not going to get any better, and they have no hope. Definitely keep an eye out for that. And when they lose hope, they also lose their reasons for living. When I'm doing assessments, I talk to people about, you know, what makes you get up in the morning or what makes you want to see tomorrow. And if they can't tell me a single thing, then that's a huge red flag.
And Natalie, you're absolutely right. I would add to that as we're assessing hopelessness, but then also impulsivity, because impulsive behavior is also a sign, and that is what sometimes send people into a space that they may not necessarily want to go in, although they feel like they're at that space and place where they're having certain suicidal thoughts or ideations. Definitely agree. And so in moving into our next question, what immediate treatment supports can a person access if they are experiencing suicidal thoughts with a plan? And I guess in this instance, voluntarily want to use immediate treatment supports. Anyone that's joining us, and if you're on the phone dialing in, please mute your phone. Please make sure everyone keeps your mics on mute. Thank you.
Okay, so anyone willing to take that question? I will say, Anthony, you want to take that question?
Yeah, sure. So if you know someone who is, is verbalizing a plan to, commit suicide, complete suicide, you want to be able to surround that person with some type of support, right? You want to know who that person has to be near and to rely on to just communicate whatever their concerns are at any given time. You want to look at, how severe their symptoms might be in terms of depression and so forth. With the plan, you want to know if they have access to whatever it is that they plan to use to complete the suicide. You certainly want to, as best you can, gauge and encourage, gauge where this person stands, and then also encourage that the person seek immediate support, maybe from a psychiatric hospital stay. Have the person evaluated, call a crisis team, or even the police department, 911 even, especially if you're not sure that a person is, is willing to remain safe or committed to being safe, right? So folks, develop safety plans, but I don't think, lay people necessarily are familiar with that, what that looks like. So it's always a good idea to reach out for professionals. And again, dial 911, they typically know what to do. They'll contact the crisis team and to ensure that that person is safe in that moment. And then after the assessment, folks can come in, like Natalie or Tangee come in, they'll do their assessment and they'll look for hopelessness and things like that. They'll look for whatever supports do exist, who is there to, be able to maybe keep an eye on the person, and then kind of, perhaps lead that person to counseling or something.
So Anthony,
Yeah,
one of the things you said was supports. So let's say I'm the loved one of a person who is saying, "Hey, I want to commit suicide. I'm going to swallow all these pills." If I'm there with them, should I remove the pills from them to access? Should I remove the gun?
Yes, absolutely. Yeah.
Okay. Should I remove the knives? Those type of things.
Absolutely. Yeah.
Okay.
If I could add to that, is that okay?
Yes, please.
I think, like Anthony said too, if you're in the home, if you have a relationship already with someone who's in need of support, if you get consent from them to speak to that emergency contact, then follow through with that immediately. If there is no relationship and someone is in imminent danger of hurting themselves, then of course we know there's the National Suicide Prevention Lifeline. You can also text that. And these times, especially with racial uprisings and so many people in the Black community dying by the police, I used to inform people, if you're going to call 911, ask for EMT. I would say now just call EMS directly without police intervention if possible, especially if there isn't means to a weapon of some sort. Also, if there is another person in the home and you can walk them to an emergency room, or if you can drive them to an emergency room, I would do that for them to be, supervised and held for 72 hours if they should be observed for that long. So I think it depends on the context of where we are. And now with so many traumas happening simultaneously, I think we need to really evaluate, if there's a mental health first aid responder in the neighborhood that we know of, if we can just go to, our local emergency room, or if we can call EMS, or walk someone to the hospital. I would say to try those different things as well, should someone not have a provider already involved.
And that was a very good point. I would do that first, Asha. You brought up a very good point. Drive them yourself, right? If you don't have to call 911, you drive, take them out.
Yeah, and that and a question that we're going to go into is pretty much tapping into just that. So our next question is actually asks about what is crisis prevention treatment, what's a safety plan, but then also what's the correlation between underreporting suicide threats or calling on the police, considering the current and historical climate as we relate to police murders and brutality. So we're going to call it what it is. And let's expand a little bit on that. Like, as we talk about treatments, what is crisis prevention treatment? Can y'all clarify for our viewers, what is crisis prevention and what are the questions we want to ask to assess the suicide risk, maybe before we're calling on those treatment supports to come in, to make sure that that's where that person is and we recognize what level of help we need. Do we need to call non-emergency second responders, or do we need to call 911?
Well, part of assessing for crisis is distinguishing between ideation and the person actually having a plan, means, intention of killing themselves. And sometimes practitioners get a little jumpy when a person says, I have thoughts. But for some folks, ideation is their baseline, meaning because of trauma, because of symptoms, the suicidal ideation is something that they live with every day. And they don't have a plan to kill themselves, but it's part of their thought process. And we can work on that during counseling, but you have to delineate between what's part of their normalcy that we can work on in counseling and what is suicidal ideation with a plan. So through that questioning, you just have to ask them, okay, are you currently having suicidal thoughts? What are those thoughts? Have you told anyone about those thoughts? And have you thought about the means of killing yourself? Have you researched the means of killing yourself? Is there a plan? Did you make a plan of exactly what were you going to do to kill yourself? Is there a specific time? Is there a specific date? So being as specific with your questioning to this individual and gathering as much information from that conversation to determine whether you need a second level of intervention versus, okay, let's develop a plan. I don't like using safety plans because inevitably we have to do our jobs to ensure a person's safety, make sure that we as mandated reporters are contacting the authorities, giving them the resources they need to contact if they are feeling suicidal. But there are sometimes individuals that we don't know are suicidal that will still take their lives by suicide. And we have no control over that. And you still have those clients that will come to you and say, yeah, I'm having these thoughts, but I have no intent of killing myself, and will walk out of your door and still kill themselves.
Yeah.
So we have to be very real about that. So I do like to create what I call a coping contract. Let's talk about what coping skills you can use to deal with these suicidal thoughts. Do you draw? If you draw, when you're feeling suicidal, this is one coping skill you can use. If you play video games, okay, that's another coping skill you can use. Who are two individuals part of your support system that you can contact to talk with you if you're having these thoughts? Of course, you can contact me if you're having these thoughts with no plan, but I'm going to put down here the local crisis line, because if you're having thoughts with a plan, this is who you contact, because I'm not on call 24 hours a day, and these are the people you need to contact. And you also can contact 911, 1-800-SUICIDE, all these other numbers, so that you can be assured that you have resources available for you. But if you ever get to the point where an individual has details of a plan. They've already made the decision to kill themselves. They are resistant to you intervening and talking about coping skills. They prepared and they put their affairs in order. Then that's when you need to go to that second level of intervention.
Great points, Dr. Roney. And just to kind of reiterate what she said, ultimately the questions we're asking is to find out, is there an intent? Is there a plans? And is there the means to act on those plans? And more importantly, as far as crisis prevention, safety plan, or like you said, a coping plan, we're identifying what are your warning signs, what are your coping skills. If you're unable to use those coping skills or there's obstacles in using them, who are trusted family members or friends you can contact, who's your professional, and then when your professional, i.e. your therapist, is not available, who else do you call? And oftentimes we'll identify a community service board, different other crisis centers, but also then ultimately, in some cases, the police. And so as we think about what you just said in terms of just identifying the coping strategies, and I'm just looking at the question that we had, a big piece of that is just kind of acknowledging what are ways we can prevent this crisis from going any further so that we're not acting on our thoughts. And Mecca, do you want to move to the next question, or does anyone want to add to that?
If I could just add one thing, I would say from the perspective of a layperson, because we have a lot of people here that are, I imagine, lay people and don't know what should they do if they're listening to or they're witnessing. And in some states, you may be held accountable if you're a bystander and you don't do anything. And so some of the things we can do, like Dr. Roney said, is we can talk people through identifying a couple of strategies that they can go to help them regulate themselves and soothe themselves should they feel flooded with emotions and thoughts. And so they can label what those things are. I think also what we can do for people who may not know of any other resources besides calling 911 is to, in your state, if you have 311 or 511 or just a hotline that you could call for the hospital closest to you, most hospitals have a mobile crisis unit. And so there may be either a psychiatrist or a nurse practitioner or a social worker available who's on call 7 days a week. There's someone in rotation that you can identify that can call you should someone be in need of imminent care and you don't know what to do. So if you're not sure of the local hospital's number, or you don't know the hospital closest to where you are, if you even just either call 311 and ask for the hospital closest to your zip code and ask for mobile crisis, then you can get to someone who may be able to come out to you and do an assessment should someone need help. And lastly, if someone tells you that they are thinking of hurting themselves, every single time you hear that, if you're not a professional, you should take that seriously. So that would mean that do your due diligence, even as a friend or a loved one, to call that person back. Don't just text them. If you can't get a hold of them in a few hours, go to them if you're able to go to them, or find someone closest to them to visit them. Ask them for the permission should you need someone who is an emergency contact to reach out to if they are in imminent danger. And you can even ask if they are having suicidal thoughts, how often do they have those thoughts? Have those thoughts intensified over the last 24 hours? And then, next step, what is their intent? What plans do they have? What means do they have, et cetera? So that if they need to journal that down to monitor, okay, I'm having a few thoughts per, 5 minutes, or maybe I'm having one thought per hour, or a thought every couple of hours, they can see and track for themselves as well. Like, oh, okay, I'm feeling a little bit more regulated, a little bit more at ease. I'm doing these other things help me to cope. I know I can call you should you be available to me, et cetera.
Thank you. Thank you. Another thing I want to add to that, as far as a resource, some people can call their insurance company, such as I used to work for Magellan, and we would take crisis calls when people felt suicidal. We would walk them through it and do an assessment and act from there. Call the local hospital, the local CSB. So definitely you can always access your local insurance company. It may sound odd, but they have licensed professionals to handle those types of incidents. Okay, we're gonna move on to the next question. Is there a correlation between underreporting suicide threats and the current and historical climate in reference to police murders and brutality? And in the Black community, that is.
I mean, I would say so. I don't know of any statistical information or evidence of that as yet, but in some of the self-reports I've learned about, especially with Black men, they're not going to tell people that they're suicidal, especially if they know police are going to be involved and it's going to end up tragically. And that number probably, you know, could be whatever we think it could be, and growing in numbers with women as well, because women are also being murdered by the police. So unfortunately, our community is the last community that gets adequate research when it comes to intervention, treatment, and prevention as is, and a lot of this empirical evidence.
Anyone have anything to add to that?
I think someone touched on this earlier when they talked about risky behaviors. There is a term that they've coined, suicide by cop. So someone could be feeling suicidal and not report that, and intentionally try to get the police to kill them. So that could be some of this. Now, some of what we've seen, and I won't delve into that because that's not the topic tonight, that has to do with suicide, but yeah.
So are we saying there could possibly be a correlation between the underreporting and just the historical tension and contention between police and Black people?
Yeah, absolutely.
In certain communities, that is.
Mm-hmm.
Okay.
I would say so.
I've been involved in situations where a client is expressing suicidal thoughts. You mentioned the police at all. It's like, oh, I'm good. Because not even fear, just getting murdered or beaten up, just getting arrested, being charged with something. They may have the fear, the paranoia that if you call the police on me, I'm gonna get not treatment but locked up.
Mm-hmm. Or they're going to come to your house and send a social worker who's going to investigate your home, and you know, all kinds of things will happen to your family.
Mm-hmm. And then we've seen how the police has handled mental health calls recently in the media. Individuals having mental health emergencies and their family members contacting the police to get help for those individuals, and those individuals being shot dead.
Mm-hmm.
So I believe that has a lot to do with people underreporting. And then the transgenerational trauma of the mental health system on Black people as a whole, of being misdiagnosed and experimented on, and not wanting to seek treatment in general, but then having to call the police to intervene for a possible suicide threat. It's like a double whammy. And we know historically Black people, especially Black men, have been overdiagnosed as having schizophrenia for years. So then, you know, that being an underpinning of our culture. And then now we have individuals that are experiencing suicidal ideation. They just don't want to have anything to do with the medical community because of the distrust.
The general distrust. Thank you. So I'm gonna, for the sake of time, to allow questions from the people who joined in this evening. We only have a few questions left. Gonna get through these questions, and hopefully if only one panelist can answer the question. Tangee, you want to take the next question?
Yeah, and I think you guys kind of touched on it. It was basically, can crisis intervention occur with the police or with police intervention? And I think you all pretty much tapped onto that it can, but there's reasons for which we don't necessarily often want to call on them because of historically what has happened. But we know that there are cases where us as therapists may not be able to handle it alone, and there are reasons for which we may have to call 911. But the question following that is, what other types of ongoing treatment can a person access with when they have a history of mental illness and suicidal ideations or attempts?
Anthony,
I'll be quick. I think just there's a lot of focus these days on individual treatment. And I found that group therapy heals people in much more powerful ways that individual treatment sometimes takes longer to do. So when I speak to people about mental health care, I try to broaden that conversation, especially since there's only 4 to 5% of mental health professionals that are people of color. That's such a small percentage with the numbers of people we know actually need and can benefit from care. So I look at everything from, let's say, the most extreme, like a hospitalization or a partial hospitalization program, or even a day treatment, then down to outpatient mental health through group support. So that's facilitated group therapy, that's peer group support, that's also spiritual groups that are in existence for people who either suffer from substance abuse or other disabilities, to then couples therapy, family therapy. You can get pastoral care. You can get spiritual counseling from a licensed mental health counselor as well. And then you can look at individual therapy too. And I also think the other ancillary services are great supports for people with mind-body connection. So mindfulness and meditation, mind-body treatment, movement therapy, art therapy, play therapy for children and adolescents. There are all of these other modalities that we don't speak about in our communities because we often talk about either you go to a hospital or you go to an individual provider. If you don't have insurance and you can't pay out of pocket, then you go nowhere. And that's not the case. There are all of these other ways that people can receive help and support. And it really does help when people are in groups because the power of the group is just so magical.
And there's an accountability in the group setting, right?
There is.
You try to look forward to seeing your group members. Your group members are looking for you. Where's such and such? That holds people accountable. People, that camaraderie is everything. And it's a form of support.
Yep.
And connection.
Mm-hmm. Yeah.
Connection.
Absolutely. Yeah. And so, Asha, can you also answer our last question, which is how can family and friends respond to an individual who's presenting with suicidal thoughts or has a history of suicide attempts? Because oftentimes families want to be the primary support. They want to help, but they don't know how.
Mm-hmm. First and foremost, calmly, because it is nerve-wracking if you hear someone you care about say that they want to die, or they want to end their lives, or they've attempted to and they may want to reattempt. So remaining as calm as you can, and also pacing the numbers of questions that I think you ask someone right away. Questions are important, but either not asking questions or asking too many questions right away sometimes can overwhelm someone. So being as compassionate and empathic as you can, being a listener, even sometimes just being side by side with a person while you allow them to talk about what's going on can be really therapeutic for that person in that moment. And then I think just everything that we've said tonight on the panel, from talking about, what is going on that may have created this fear of living or desire to die or to end their lives. Have they been thinking about this for X number of hours, days, or weeks? How have those feelings, felt for them? Has it affected the way that they've been sleeping or talking to their friends? Should you not see those things? So I think remaining as calm and then slowly increasing the number of questions, trying to be as specific using the examples we gave here tonight, and then also doing your best to follow up closely, and keeping an eye on them. So if they're living with you, allowing, if possible, them to sleep close by or with the door open or with the hallway light on if you're in the same household. If they're not in the house with you, asking, can you call or check in? Don't leave it up to the person who's experiencing that distress to call you or reach out only. Also make yourself available to them and give a timeline as to how soon you can follow up. Can I call you within the next hour? Can I call you again in the next day? And stay in touch with them and ask them for their plan. I often like to ask people, whether they're suicidal ideations are passive or not, what's your plan for the next couple of hours? What do you plan to do after we get off this phone call or this Zoom call? What's your plan for tomorrow? If they do have a plan as to, well, I think I can get up and go to yoga, or I can go to work, or whatever it is, that's much more hopeful. And then follow up with them and see, did they do that thing that they committed to doing, and stay in touch with them, and then proceed to say, okay, what's your next step? So take it one literal step at a time, and also invite them into getting some kind of help, even if you help them make the phone call to a provider or many phone calls to many providers, asking them when they make their first appointment, if they kept their appointment. So you really need to stay closely involved all the way through the process of them receiving the help, not just talking about getting the help.
Thank you.
That's a wonderful answer. Yes, you tapped in,
Thorough.
touched on all points. Yeah. And so now we're coming to the last portion of the panel discussion, and I've been keeping track of the questions you all have left in the chat. And so I have the question, which you all can view in the chat. I don't know how far you can go back, but this is from DeJearne. And I don't know, I'm sorry if I'm not pronouncing that correctly, but it says, going back to the topic of self-harming behaviors, I think we should be careful not to bundle self-harming behaviors with risky behaviors because there is a difference. It is important to highlight that. What are you all thoughts on that in terms of not bundling self-harming behaviors with risky behaviors? I think earlier risky behaviors was identified as a form of self-harming behaviors. What are your thoughts on this feedback?
That's interesting.
So I could see risky behaviors being more as a passive means where self-harm is active. I'm actively doing something on purpose to hurt myself. And that is the cutting, the burning, the hair pulling, the head banging, all of those kind of things. Whereas kind of just going out and taking risks is kind of like saying, I don't really care what happens to me. So if it happens, I'm not doing anything to prevent it.
Okay, good. Any other feedback?
It depends on the intentions of the individual. I think it's very individual when it comes to risky behavior, because that intentional behavior for self-harm may look one way for a certain group of people, but for another group of people, it may look a totally different way. Mm-hmm. And I'm saying this because I've worked with some clients who engage in intentional, risky behavior because they know that it will put them in harm's way.
Right. Okay.
So can you give an example, Dr. Roney?
Pardon me?
Can you give an example of an intentional risky behavior
okay.
that could put themselves in harm's way?
Okay. For a number of years, I worked with the HIV/AIDS population. So I've worked with a few individuals that engaged in unprotected sex, knowing that they could intentionally infect someone else or to become reinfected, knowing all the risk factors. But because they were dealing with their own internal issues, depression, and having suicidal ideation, it was an intentional way of harming themselves. And then the possibility of harming someone else.
Right, yeah.
I would like to add to that when we talk about risky behaviors, it also depends on, okay, there's intention and mental health status, like what's going on at the time. What would cause that risky behaviors, such as if a person is in a manic state, they can engage in some high risk behaviors that could cause them harm. Speeding, drug use.
I was going to say that so, and we think about certain disorders, bipolar, part of some of the manic symptoms would be risky behaviors. It could also include things like reckless driving. So DeJearne actually just commented again and said, or I am taking risks that might not be self-harming or an attempt to intentionally harm myself. So it's risky, but that's not my aim. And I would say like speeding, reckless driving, I'm not really trying to get in a car accident. I'm just engaging in risky behavior. I could see that there is a difference.
And maybe there's some overlap based on development and intellect too. So if the personality, their intellectual level, how do they really understand intent and risky behaviors versus it becoming self-injurious or harmful?
Yeah, so that's a good point, Asha.
That's what I'm speaking to, like more the overlap because of mental health symptoms and now cognitive issues as well. So it's a tricky situation.
Right. Yeah. Well, DeJarn said correct. So I think we answered that. She said we only know what someone tells us when assessing self-harm, which is absolutely true. Most of what we know is self-report, and then of course our clinical observations. Maria, she said, or not necessarily a question or a comment, I've heard that some of the greater deaths by suicide for men are because they will attempt by more lethal means, such as guns, while women will attempt more often, but it tends to be via less lethal methods. I guess you all agree based on some of the statistics in regards. Yeah, we all agree. Okay. Then another a question from Maria, and she said, I'm a white social worker on an inpatient behavioral health unit. Hospitalization is necessary at times, but I worry about the trauma it can cause, specifically with being held against your will and risk of completed suicide increasing after hospitalization. Is there anything specifically I should be aware of about effects, experiences of Black people in a behavioral health unit? Is there anything specifically helpful I could do, or just things I should be mindful of as a white counselor? Good question, Maria.
Wow, that's a lot.
Yeah.
That's a lot, because it really speaks to how much influence and power do you have as an individual within the system in which you work to reassess and reassign clients and clinicians. I mean, I think that's so structural, because there are different determinants that weigh in on who gets hospitalized and who does not, and for how long, and also who's involved in caretaking. So I think just continually educating yourself as a white person, and hopefully bringing those conversations into context at work, and hope that people would be willing to listen to you, because self-reports are really important, but you have to be aware that there may be a lot of times where Black clients will not share things with you simply because you are white, and you have to accept that. So educating yourself and having those conversations, following up with clients about their view as to how they were treated as well matters, and being sensitive should they not want to tell you or disclose too much.
And I'll chime in as well. Oh, I'm sorry, you can go ahead.
I worked on an inpatient unit for a number of years, and that's a very unique experience. So as a white provider on an inpatient unit, continue to educate yourself about cultural competency, and as was spoken about before, involving the family is very important, and making sure that Black people are connected with providers of their preference for discharge. That shows that you are interested in what they want and they need. And making sure that their experience in an inpatient unit is not traumatizing. So providing them with those supports and asking them about those other aspects of their lives that may be contributing to symptoms, because I think a lot of times mental health professionals, especially in the medical setting, are quick to give that one major mental health diagnosis that fits that symptomology, and not take into consideration the social environmental factors. So if you can speak to that with the other providers, saying, hey, this person comes from this type of environment, this is the type of trauma they've experienced, so maybe that's not the most appropriate diagnosis, or let's take these things into consideration before slapping that label on this individual. I think that would be helpful. So looking at the individual's diagnosis from a cultural context would be helpful as well.
I would like to add to that, to Dr. Roney's comment. One of the things I see often when it comes to Black people, the misdiagnosing, especially in the hospital setting, it's like bipolar disorder, because that's what the symptoms present like. But when you take in cultural context, environment, it's probably trauma in addition to, or, because sometimes the symptoms can look very similar. So I think just doing a little bit extra to kind of find out some of the background information, that's with the collaboration of the family comes into play, and any involved treatment providers.
And I want to add to that, Mecca, involve treatment providers. So Maria, I would also say everything they said is definitely exactly what you ought to do, in addition to working with the providers, especially when you have providers that coordinated that care. So recently I actually had an actively suicidal client. And what I often do is if this is a situation, and typically I can have clients voluntarily say, I'm going to go, I call ahead. I call the emergency ER. I talk to someone in the behavioral health unit. I give my name, information, my client's information, say they're coming, and here's what you need to know. I've done that recently, and I'm not going to say this hospital that I recently had to deal with, but no one contacted me during the time my client was there and when my client was discharged. And I am the person who coordinated my client going. And I felt slighted because the initial person I spoke to, I'm like, this is all the information I want to be contacted. I want to be a part of the process because I know the state my client was in. And even hereafter, I faxed the releases and everything else to get even the discharge summary and nothing. And that experience was, I don't want to say that it was beneficial. I don't want to say it was hurtful or harmful to her. She's okay and stabilized now, but that could have gone a long way. And even still now, her view of the hospital is, I don't want to go, I'm not going to go, and they don't really care. You know, she said nobody gave a when she was there. You know, and that's not the first time that's happened. So interestingly enough, DeJearne, she actually made another comment that's kind of overlaps and kind of speaks to some of this. But she said, as a person that conducts emergency crisis evaluations, it is important to really explain to clients what is going to the hospital actually mean, and that they can be held against their will. So the involuntary part. Sometimes that is extremely overwhelming for the individual, and they might avoid seeking that option in the future. Wellness plans are great for identifying solutions from your least restrictive to the most restrictive. It's my experience that many clients are not always informed and they don't know what to do or what to expect. I want to say this same situation I just mentioned, they told my client the day she got there that she would be going before the judge. Again, the system has failed. I called and coordinated. This was a voluntary situation, and they were mistakenly about to put her in front of the judge for involuntary. She was able to clear that up. Then someone actually read the contact information. But again, this is an area of concern. And this is, again, another reason why it's underreported or there is not access to treatment for the Black community.
And we have a comment from Daryl Frazier, LCSW. He said we really need to deal with racism in the healthcare system. Absolutely. And so that's what everyone who works in the healthcare system, we all need to work together and combat this and make sure we're doing a thorough job as much as we can to make sure the treatment is coordinated appropriately and we're working in the best interest of the client. It may take some time. You may feel like, oh, I had a long day. I was about to get off from work, but we have to act in the best interest of the client. We do the best thing for the client. We're doing the best thing for society.
One thing I would like to add too, so when a person is admitted to an inpatient unit, you know, as an assessor, you're looking at determining what disorder you're treating and what symptoms. I think it's important to ask the patient, in this case, how they want those symptoms to be treated. So I think that's important.
Absolutely.
Because not everyone that goes is open and receptive to medication, but oftentimes that's the first form of treatment that is given even before they are evaluated by that psychiatrist or meet with that hospital therapist. Curry shared treatment shouldn't matter on insurance, location, or dollar signs. This is a major barrier, I think we can say, for our Black community. Insurance, disparities with healthcare, absolutely.
Location.
Yeah.
Location can be a barrier as well.
Yeah, this is true.
And another thing we don't often mention is language, because we think of Black people as only speaking English, but there are a lot of Black people who do not speak English as a first language. And we don't have enough providers that speak other languages, French, Spanish, Creole. And so that's also valuable too. So if there's a person involved in that, you know, individual's life and their household that can come along with them and interpret, that's also really valuable because symptoms also get interpreted in different languages differently. So that's also really meaningful.
Very true.
You know, I just think, I understand it's really hard when you're on the inpatient unit because you have a short window to assess, evaluate, diagnose, and treat. But, you know, people who are already mistrusting of these symptoms need extra special care.
Yep. I want to speak. Okay, was that Anthony speaking? Somebody was speaking.
Oh, I just said very good point.
I just wanted to add on to that when you said not every Black person speaks the same language. We have Black people from different backgrounds. That's part of the reason why I was intentional about, instead of saying African American community, because we use that a lot, I said Black, because I was speaking to anyone that is a descendant of the African diaspora or appears to be. So I wanted to be very intentional because we have Black people in this country from all walks of life, all different types of cultures, countries, everything. And I think that the similarity is just this barrier with the healthcare system, in particular the mental health system. Did we have any other questions?
I think we had a comment. DeJean said, you guys are great. I think you should consider doing more of these for community providers, agencies, as well as families. It can be a great informational tool. Great job. Maria said, thank you. She really appreciates our answers. All of it was super helpful feedback. And so as we coming to a close, we definitely want to take any last remarks from you all, our panelists. And then we also want to tell all of our viewers to please complete the survey. We've dropped the link in the chat box. So please complete the survey. You'll be entered into a drawing to get a gift from a local Black-owned business. Winners are going to be announced October the 1st. So for more information about the Style Effect upcoming events, the website is provided for you in the chat space. So again, please, if you enjoy this event and want to provide feedback, please complete the survey. The link is in the chat box. But each of our panelists, we'd like you each to take a turn and give some last remarks and just tap into, different things you want to leave with our viewers. And resource information for you all as well.
Wait, Tangee, one second. Someone's asking about resources in the DC or Maryland area for counseling or therapy.
Excuse me.
Well, I would say definitely use some of the search engines where you can filter location, preference, ethnicity, assurance, psychology today, therapy for Black girls, therapy for Black men. Those are some good search engines. Also, VirginiaBlackBusinessDirectory.com, Blocal. Those are all directories where you can find resources for mental health needs, if any, and then look at that person's community service board within their locality, which is typically a one-stop shop for services that's related to therapy groups and whatnot.
And that's nationwide.
Yes, and I'll drop those links, Danya. Sorry if I'm mispronouncing.
Also, check out the ECA website, and the link is in the chat. And some of you all join later, and if you please check the link out in the chat. Also, we'll explain the Style Effect Project, which is powered by Richmond Memorial Health Foundation. I am the artist, and I am in collaboration with ECA, and we are bringing these events in the merge of art and health. The health is mental health, and the art is fashion and style. As you see all the panelists today, we wore purple and teal to represent Suicide Prevention Day, Worldwide Suicide Prevention Day, and the month of September in support.
So Natalie, let's start with you. Any last remarks?
First of all, I just want to say thank you all again for coming out. Please let this just be a start. Myths sometimes can just infiltrate and limit our knowledge. And I encourage you all to keep getting educated to learn, what the truth is so that you can more effectively help friends, family, clients, loved ones. Understand also that when people are talking about suicidal thoughts, there's a difference between wanting to die and actively wanting to kill yourself. So the biggest thing is when someone starts to talk to you about these things, please listen. Listen without judgment, and listen with the intent to help that person. Know your resources, but also know all that comes with each of those. We've talked about therapy, we've talked about hospitals, we've talked about all of that. Do understand that sometimes people can go to the hospital voluntarily and it can become an involuntary situation if they get there and people see enough warning signs that now they want to leave. So do know that. Please keep in mind the least restrictive options possible, but when in doubt, always go to the higher level because you don't want to take a risk. If someone ever tells you that they want to kill themselves, believe them and meet them there to intervene, because you don't want to try to call someone's bluff and then have something happen.
Thank you, Natalie. That was helpful. Anthony?
Yeah, well, I certainly want to thank you, Tangee and Mecca, for putting this panel together. And you ladies, all of you are amazing ladies. It's my first time, have an opportunity to kind of hear what you all are offering. And Dr. Roney, I know I've been knowing you for a while. But again, thank you. And then definitely want us to continue having this conversation. I know there are a lot of professionals here, certainly on the panel, but I guess people who have joined the meeting are a lot of professionals. It's our job to talk about mental health. So we're going to continue doing that. For all the lay people here who are, listening in, I want you all to talk about mental health because, the topic was suicide, but we're only talking about suicide because of mental health issues primarily. And, one of the things that, I mentioned in my work is that, we don't learn about mental health until we have some type of mental health problem. So if we can have that conversation early on, I think it would help resolve some of the myriad disorders that people are experiencing. It would certainly work to reduce the number of suicides we have. And, certainly thoughts. Talk to people about their thoughts and thinking. Reinforce the importance of attending therapy, right? Because therapists help people manage their thoughts. We all have thoughts. And again, unfortunately, we go to school, we learn to, count and to write and read literature, but we don't learn to manage our thoughts. So this is kind of what we do as therapists. We help people manage those thoughts, and which ultimately, when we can manage those, we can manage our mood and our behaviors. So again, thank you all, and that's it.
Thank you, Anthony.
Thank you.
Dr. Roney?
I really enjoyed being with you all this evening. The discussion is definitely necessary and it's definitely needed ongoing. One of the things that I talk with interns that I supervise and residents that I supervise is about normalizing our experiences. And part of us developing as counselors is self-reflection and our own individual growth. And I believe that to be so as lay people, as people, human beings in general. But normalizing our experiences connects with clients. And when it comes down to suicide, the majority of people have had suicidal thoughts at some point in their lives. And if we can just normalize the fact that sometimes you have these thoughts, sometimes things happen to you and you have these thoughts. But how do you cope with them? What do you do? What are some resources? When our clients hear that this is a normal occurrence, something in them changes. Like, oh, is something not wrong with me? No, nothing's wrong with you. This is something that is normal. But what can I do to help you? And I think that's the issue with mental health in general. We don't necessarily talk about the normalcy of depression, anxiety, and these other things that's part of the human condition. And because of that, when people have thoughts and feelings, they think it's something wrong with me, it's something different when they're just going through life. So I think it's really important that we start normalizing people's experiences, and then educating them about what is outside of the norm. Because there are a lot of young clients that I see that may be experiencing anxiety, but it might be just normal anxiety. Well, normal anxiety, it could be a good thing. Normal anxiety make us perform well on a test. Normal anxiety promotes us to do our best. But outside of the norm, it may cause us to isolate in our homes. It may cause us to have a panic attack. So we just have to educate them on what is normal and what is not normal. I think that would be really helpful. And the same thing with suicide. And I think everyone can contribute as an individual. Everyone has something to contribute. So if it's just intervening with a friend or a family member that's having a difficult time and talking them through, or giving them resources, or driving that person to the hospital, is something that all of us can do.
Thank you, Dr. Roney.
Thank you. Asha?
I wanted to echo that last part because it was a pleasure to sit here with everyone tonight and all the panelists as well. Thank you for having me, Tangee. Thank you for having me, Mecca. I hope that everybody walks away knowing that we can all be an active participant in our mental health prevention and wellness, and that if you forget anything that we said here, follow us if you're any of you on social media, because a lot of us, I know myself included, we use our social media platforms to provide resources, provide space for you to be able to talk to us, not to use it as therapy because it's not for that reason, but it is to connect, to link to resources, to maybe navigate you to the right professional, and also to remember that there are a lot of ways in which you can receive help. And so during times like this, when we're in a pandemic and providers are doing remote care, you may not be able to get into an office to see someone right away. You may be able to do other things that we've mentioned this evening in the form of group therapy, art therapy, play therapy for your children, family therapy, even through these types of ways. So there's something that we can all do for ourselves. And just lastly, I just hope that we remember who we are. Part of trauma recovery is remembering the coping skills that work until they no longer work, and then we find new coping skills that are healthy and adaptive. But that what our ancestors went through in the passage to come here was the beginning of this conversation of suicide when they were jumping over ship to save themselves from enslavement. That was the beginning of suicide. So when we say we don't commit suicide or die by suicide, that's a real myth based on the history of our people to save themselves and to not have to endure more suffering. But we don't have to do that now. We can remember who we are, what we came here to do, that resources are in many places, and to trust your gut that if you intuitively feel something is not quite right, or there's a loved one that is dealing with something, trust your intuition and ask directly, ask questions. They will be appreciative of that.
Yes, thank you, Asha.
Panelists, can you all put your social media handles in the chat so people can access you if you would like?
Yeah, thank you. And I just want to touch on one last thing, and then Mecca, I'll turn it over to you to close out. Okay. But Asha, you made such a good point as we were talking about social media handles and things. I think the last thing I want to share is tonight there was about 35 people total on this call, and there's going to be more viewers as we share this recording. I think it's very important that we take the information that we've gained tonight and we use it to help someone else. Right before we got onto this call, someone shared with me a screenshot, and they said, what do we do when we see something like this on social media? There's the 64 comments, but none of them is giving this person information. The person had posted a status stating, it's really been hard for me, and today I really wanted to die, and I really thought about taking my own life. And so the question was, to me, was what do we do when we see that? What I've seen when people have stated that I'm depressed, I want to kill myself. I'm feeling this way on social media, as people are saying, pray on it. It'll be all right, praying for you and things like that. This isn't to minimize religion and spirituality, but this is to say, when we see something, it's our, at least for professionals, it's our ethical duty to society to reach out and share resources and attend to those persons in need. But I think all of us, as we're on this call, you find it important to conversate about this. Ask someone or how they're doing, or reach out and say, here's some information for a professional. We're not asking you to respond as a professional, no, but at least give them some tools that they can get more help than saying to them things like, I'll pray for you, pray on it. So I really think that what we've gained here tonight is I can't even say how much, but a lot of information that now you know how you can at least respond and direct someone to a professional so that they can seek the help that they need. But thank you all for joining us. It's been a pleasure. And Mecca, I'll turn it over to you to close out.
Okay, thank you all. Thank you to all the panelists. I really appreciate you all participating. This has been insurmountable. For everyone who came in to join into the conversation, to listen, thank you all for coming. Also, please, 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 please take the survey. It's in the chat. Please take the survey to give us feedback on what we could do differently, things you want to know, what we did really well, how often you would like to see panels like these. And I want to also apologize. This was supposed to be on Facebook Live, but I had technical difficulties for whatever reason. My computer just dropped the Zoom and I could never get back. So I apologize for that. But hey, here we are. It's adjustment. Yeah, that's life. Life is gonna life. But we still got through it. So thank you. Also to the panelists, we would like to send you all a token of our appreciation for being here tonight. And if you could take the survey and put your name and mailing information in the survey, I would email that information, or you can, just use the information in the link. That would be so helpful, because I would definitely want to make sure that I send out your gifts. So thank you all for participating. Oh, and one more thing. Tangee and I are also part of another group called Cut to the Chase. And we have an upcoming discussion. It's a men's group, and women are also welcome to this. We have another discussion coming up on October 4th from 1 to 2:30. That's gonna also be on Zoom. Those flyers will be coming out tomorrow. We're gonna talk about Black men and addiction. That's gonna be interesting. So please join us for that. Really good discussion. And we do these discussion groups at least once a month or once every quarter since COVID. But please come to that and look at our social medias and you'll see the information for that.
Awesome. Thanks, Mecca. Thank you, everyone. We look forward to seeing you next time.
Bye.
All right. Well, without further ado, we're ending on time. Thanks, guys.
Yay.
Have a good one. Bye.
Bye.